All right, everyone, welcome. As you all get ready to start your pediatric clerkships, I really want to walk you through a case that I guarantee you're going to see. We're going to do this grand round style just to make sure you feel totally ready on day one. So let's dive in. Okay, so picture this. It's your first week on peds. A 12-year-old boy comes in, and this is the story. He's super thirsty, he's going to the bathroom constantly, and he's dropped 10 pounds in just a few weeks. Right off the bat, what is screaming out to you? What's at the very top of your differential diagnosis? Just hold that thought as we meet our patient. This is David. He's 12. And it is so important to remember that behind every lab value, behind every symptom, there's a person. There's a kid whose whole world is about to change. So our job isn't just to be data crunchers. It's to figure out why this kid is sick and how we can get him back to just being a kid. So his parents bring him in. The chief complaint says it all. He's thirsty all the time and wetting the bed at night. And this has all been happening for about 3 weeks. They say he's drinking gallons of water a day. That's your polydipsia. The bedwetting is totally new for him, which is a huge red flag for polyuria in this age group. And get this, even though he's eating more, he's lost 10 pounds. You add that to the fact that he's tired and irritable, and, well, a pretty clear picture is starting to form. And that picture brings us to something you absolutely, positively have to know. This is the classic triad of type 1 diabetes. You've got your polyuria, polydipsia, and weight loss. I'm telling you, if you see these 3 things together in a kid, type 1 diabetes needs to be number 1 on your list with a bullet. Burn this into your brain. You'll need it for your exams, and you will see it on your clerkship. Okay, let's move on to the physical exam and see what we find. His weight confirms the history. He's 40 kilos, down from 44.5. His mouth is dry, his mucous membranes are tacky. Classic signs of mild dehydration, which makes total sense. But here's what's really interesting. It's what we don't see. There's no acanthosis nigricans. You know, that dark velvety skin you can see in the neck or armpits? Why does that matter? Well, it's a sign of insulin resistance, so not seeing it makes type 2 diabetes a whole lot less likely. So, the story and the exam are all pointing in one direction. Now, the ball's in your court. You're the clinician. What are the next 3 tests you're going to order right now to lock this thing down? Think about it. What's going to give you the most definitive answer fast? First up, a random plasma glucose. And wow, David's is 450. To give you some context, a normal reading is under 140. Anything over 200, especially with symptoms like David's, is diagnostic for diabetes. So with this one number, boom, we've confirmed it. He has diabetes. Next up, the hemoglobin A1C. His comes back at 11.5%. Now remember, A1C gives us the long view. It's like a batting average for his blood sugar over the last 2 to 3 months. A normal A1C is below 5.7%. So 11.5 tells us this isn't just a fluke, this isn't from a candy bar he ate this morning. No, this high sugar state has been going on for weeks, which lines up perfectly with what his parents told us. And finally, the urinalysis. This is another huge piece of the puzzle. It shows 4+ glucose. That means his blood sugar is so high, his kidneys just can't keep up. They can't reabsorb all that sugar, so it spills into his urine. And when all that sugar goes into the urine, it pulls water with it. That's a process called osmotic diuresis, and it's exactly why he has to pee all the time. We also see 2+ ketones. This is critical. It means his body is so starved for energy at a cellular level that it started burning fat for fuel, and ketones are the byproduct.
So all the pieces fit. David has type 1 diabetes mellitus. Let's be really clear about what that means. This is an autoimmune disease. It's an inside job. His own immune system is mistakenly attacking and destroying the beta cells in his pancreas. Those are the specific cells that make insulin. The end result is a severe or even absolute lack of insulin.
And to prove it's autoimmune, we check for specific autoantibodies. Think of these as the fingerprints of the immune attack. And sure enough, David's panel is positive for GAD65 and IA2 antibodies. These are the smoking guns. They confirm this is type 1A, the immune-mediated kind. This also lets us stage his disease. Stage 1 is when you just have the antibodies. Stage 2 is when the blood sugar starts getting a little wonky. But David, with full-blown symptoms and hyperglycemia, is squarely in stage 3.
Okay, so we have our diagnosis. But to really get this, to really treat it well, we've got to go deeper. We have to understand the pathophysiology. What is actually going on inside David's body? I like to call it the silent war. So let's zoom way in to the cellular level. Insulin is like the key that unlocks the door to our cells, letting glucose in for energy. Well, in David's body, there are no keys. So even though his blood is jam-packed with sugar, that's the hyperglycemia, his cells are literally starving. And that starvation mode is what triggers the body to break down fat, which explains his weight loss. And all that glucose just trapped in his blood, that's what causes that osmotic diuresis, the constant urination, and that intense thirst. Now, this part is pretty mind-blowing. His parents said symptoms started about 3 weeks ago. But this autoimmune attack, this silent war, it's been going on for years. You see, the body has a huge reserve of these beta cells, so symptoms don't even show up until this tipping point is reached, when about 80 to 90% of those cells have been completely wiped out. So to the family, it feels sudden, but the battle has been raging under the surface for a long, long time. So what do we do about it? Where do we go from here? Well, this is where we come in. Our job, along with David and his family, is to essentially become his external pancreas. We have to give him back the insulin his body can no longer make. So let's talk about calculating his starting dose. This is super high-yield stuff. We'll start with a pretty standard rule of thumb, about half a unit per kilogram of body weight per day. David is 40 kilos, so his total daily dose is 20 units. Easy, right? Then we split that 50-50. Half of it, 10 units, will be his basal, or long-acting insulin. The other half, the other 10 units, is his bolus, or mealtime insulin. We'll just divide that up between his 3 meals, so about 3 or 4 units with each meal. Now listen up, because this is a huge clinical pearl, a classic trap you need to avoid. A few weeks after starting insulin, a lot of patients go into what we call a honeymoon phase. Those last few remaining beta cells, now that they're not so stressed out, they kind of start working again, sputtering out a little bit of insulin. So his insulin needs might plummet. Parents might think he's cured. He is not. This is so important. You never stop the insulin, ever. Continuing a very low dose helps protect those last few cells for as long as possible. And treatment is way, way more than just writing a prescription. We have to think about the whole person, the whole family. This means creating a support plan for him at school, educating everyone in the family, teaching them how to manage insulin with sports and exercise, and always, always screening for mental health challenges like anxiety or burnout. It really takes a village. And through every step of this journey, we have to keep one thing front and center. It's the core principle of pediatrics. David is a kid first and a patient second. Our number one goal is to weave this treatment into his life in a way that minimizes the burden of the disease, so he can just get back to being a 12-year-old boy. Okay, so let's wrap this up and bring it all home. When you walk onto that ward for your first day of peds, what are the absolute must-know takeaways from David's case? Here's your checklist. You see the triad: peeing a lot, drinking a lot, losing weight. You suspect type 1. You confirm it with high blood sugar and those autoantibodies. You understand the why. It's an autoimmune attack destroying beta cells. You know the treatment. Replace what's missing with a basal bolus insulin plan. And you always remember the goal isn't just about controlling numbers, it's about empowering the patient and preventing problems down the road. I want to leave you with this one thought. As physicians, as nurses, as the whole healthcare team, we are a bridge. We act as David's external pancreas until a cure is found. That's our role, and it's a profound privilege. Now go out there and be ready. Good luck.